All right, good afternoon, everyone. So welcome, and thank you for being here in person. And those who are online, we're going to go around the table first to introduce ourselves and then see who is joining us by phone. And then we'll go through the agenda quickly. And this is Shulay Chilakul from HSCRC.
Claudine Williams, HSCRC.
Linda Bartniska, Maryland Healthcare Commission.
Gene with MedChi. Mitchell Omax with St. Agnes.
David Hara with Chris.
Tricia Roddy, Medicaid.
Laura Spicer, Hilltop.
Frank Campbell, Health Spring Cigna.
Tracy Laval from the Maryland Hospital Association.
And anyone from the webinar?
Raquel Sampson, MH.
Go ahead, please.
Raquel Sampson, DHMH.
Hi, Raquel. Anyone else who are the work group members on the webinar? Patricia Travis. Maybe she doesn't have the microphone. Andy Fitzsimmons from Care First. So we may have. So you should be able to speak on your free will, but if not, I think our webinar people are going to figure out the way to give you the access to the microphone. And I apologize for the inconvenience. And you can also type your questions or comments, and we'll try to catch up with you that way as well. So in the agenda for today, we have the first agenda item, the review of the report. We sent you the draft based on the discussions we had and the PowerPoint presentations we had. First, we're going to review that report and then talk about the roadmap for infrastructure care coordination. And lastly, we're going to kind of recap what the role of the work group is and what should be our future plans are. So for the first agenda item, instead of another PowerPoint, I thought we could just walk through the actual draft report. And I think the substantial, we would appreciate if you have any comments or word submitting that, we would welcome those kind of things by email, and we would use this opportunity to think about more broader comments and things that you think we should miss or we should include in the report. So I think after the background, probably most substantial discussions are on the principles and the desirable features that we had in the beginning. I'll just open maybe in general if you have any initial comments. If not, we can also specifically talk about each section separately.
I thought you did a very good job capturing our conversation. Overall, I was pleased with it.
Great. So on the principles, we listed 6, and we tried to explain them a little bit more. Do you have any comments on the principles? So maybe I'll go through for the people online. The first one is that Medicare data should be accessible to different providers. Second is it should be transparent. Third is the gaps. We talked a lot about the gaps before. That should be addressed through other data resources. And the fourth is the collaboration and the leveraging the existing resources. The fifth is about achieving the goals through an interoperable system. And the sixth is maximizing the existing structure and the capacities. We had extensive discussions on that, so I'm sensing that we captured it all, so that's great. And then we talked about the desirable features, and it's hard to separate them a little bit, but at the same time, these are more concrete things. If you are creating a common structure, what should be the characteristics of that common structure is to have an independent and broad-based governance to ensure data security and confidentiality. It should be efficient and scalable, and provide access to different tools, to different variety of capacity. The fifth is the integration between the HIE, that we talked a lot about it. And the sixth one is to be flexible for different uses of the data. And then silence is going to be okay. Right. On the recommendations, so I also will give you some update. The first recommendation is, focusing to get the Medicare data. The DHMH, MHA, and HSCRC, MHCC, and most of the attorneys are working to find a way to get that data to us. We still couldn't secure the confidential elements that we need for care management resources. We had a parallel track where we were asking for a non-confidential data, which is way kind of on the road, and we are hoping to get that data soon. Soon is a relative term in the CMS world. But at least that we have a confirmation that there is a way to get that data, and even if we don't get the confidential data, we could still do something, start analytics part. If we are going to make certain models, we can start with that non-confidential data and get ready for the confidential data when it arrives. I'm hoping that those two things, we'll find a way to link them together at some point. The second recommendation is the most efficient, effective way to host Medicare data is through shared infrastructure. I think this is the most important recommendation that we have from this group. And the third is, defining the use cases and also the roles. I think we were kind of challenged a little bit, trying to come up with a data infrastructure needs without really knowing what is going to happen in the care coordination side, but it's still, these recommendations are important for people to think about because they are interlinked still. You want to know what kind of data structure you can get in order to design a system as well. So I think we are trying to bridge these two worlds together, and at the beginning we kept them separately, but increasingly I think the discussions are going to marry up together, so those who are thinking about what interventions are needed for the care intervention are going to also be discussing the data needs for the interventions that they think are most promising. So any other comments on the report?
All the recommendations are really focused on Medicare.
Mm-hmm.
Shouldn't they be broader? I would think that you'd want to have a broader strategy, not just Medicare data, but we would want to be putting forth recommendations, maybe not in the first round, but in the second phase, a broader strategy that includes all payers.
Mm-hmm. Yeah, so I think this was on purpose because this was the priority to focus on Medicare, and I'm going to talk more about the next steps where we are broadening it, but we can add another, maybe recommendation 5 to encourage the state to have a more broader discussion around data infrastructure. Yeah, that's a great point.
So along those lines, I think even assuming that all the desires to get Medicare data come through, there will still be uncertainty about the ability of CMS to deliver on those commitments. Let's say the confidential data is approved. The information I have is, for example, for SIM states, CMS has actually agreed to provide the confidential data, but has not been able to deliver. So I think that there should be something along the whole context of transitioning to this and being able to be nimble enough to, as you sort of tried to outline, Shule, responding to second-best data systems initially in case either the approval's warped or the ability to deliver on commitments doesn't materialize. Should be nuanced in here that a nimble enough approach needs to be developed in the strategy so so that the failure to get one thing doesn't cripple the entire initiative, and that the stakeholders, particularly hospitals, not the failure to say get Medicare data as timely as we hope, doesn't paralyze everyone. I think that needs to come across, because although the spirit at CMS is changing very rapidly, I think the data infrastructure at CMS remains what it was when they didn't release data very quickly at all. So I think that needs to come across, that in these recommendations, that this might be version 1, and version 2 is full implementation of Medicare data with the addition of other data sources. But I do think it's a good idea to focus on the unmanaged Medicare population initially. I think that's really important, and an area where you're dealing with populations that are not benefiting from any care management currently.
That's very good.
On point number 3, defining specific use of data, what does this mean? Trying to figure out the sort of use case that how everyone will need to take advantage of the data, or is this referring to what's permissible use of data?
I think we were trying to get them both for the request. We have to specify exactly how we are going to use that data is one question that we are all struggling. And there are more high-level use case scenarios, strategies, and things like that. For our data infrastructure perspective, I thought we were trying to get it here. Look, once you get the data, make sure you are specific enough to create these scenarios for use cases, so you can have the privacy policy, shared data sharing policies geared towards those use cases. So you won't have one privacy policy for the data. You're going to have multiple based on how we are going to use the data.
Okay. You mentioned it in the context of the Medicare data, but it would apply to the other sources of information as well, too, right?
Yep.
I wouldn't be surprised if certain organizations come up with ideas that we haven't thought about, and there needs to be, I think, a mechanism where you can sort of responsibly say, oh yeah, I understand what you're doing here, and this is a permissible thing to do, or perhaps not. But my guess is that those things will come up along the way, and you don't want to take 8 weeks to figure out whether it's because you're going to slow everyone down.
Well, so my interpretation was a little like, and you can tell me if this is the story you would tell. So we're setting up a system whereby MIA staff and us and other people can access the medical care database in a secure data warehouse, where the warehouse itself has little switches. So depending on people's privacy access, that what they can gain access to is controlled by the infrastructure switches. So I got the impression that what you were saying is make sure we build an infrastructure that can accommodate different privacy, different levels of access. And that's what I thought you were saying. Maybe that wasn't it, but
that's a better way of saying it. Yeah. But I think what David is saying, you don't want to spend a lot of time trying to come up with those use cases too. You need to find some
mechanisms to deal with them as they arise. That's something you shouldn't do some up front.
So the policy piece you're referring to,
yes.
Right?
Yes.
Determination, what is that use case, allowable use case, and then you're referring to the data infrastructure. You make sure you have that built in already, that you think about it. Okay, all right.
Can I bring up one other next step that we should talk about? And I don't know how we would say this or what we'd want, but I think it's important that we integrate it with the other reports and other work that the other work groups are doing. And specifically, I know the physician engagement, or what us at MedCai call the Gain Sharing Committee, has reported to HSCRC, and it was very positively received, and they've done their work. And in there they have this concept It's been well received of the ISSO. And I think the data needs for that should be something that we're going to want to consider. I mean, maybe we don't want to talk about that specifically, but we do want to talk generally about integrating with the work of the other work groups and the other data needs that are going to come up, and that should be mentioned in some way. I don't know how you want to wordsmith that, but I don't think anybody would object to thinking through that. So.
That's, it's going to come in the next agenda item, but that's kind of the biggest challenge of this group, how to integrate with the discussions happening in the other. But yeah, I think we need to add something.
And that one might be the good one to start with because, frankly, that one is done. They finished the report, and the HSCRC Commission seemed to like it. You know what I mean? So those two things mean that that would be the logical first next step. And then once we figure out how to do it with that one, we can use that for the model for the others.
So I had one.
Oh, yeah, so this is the trick I learned from the MHCC folks. So whenever you want to talk, you change your name tag to the opposite, so then you know who wants to talk. So that's the one.
Just interrupt people.
Some people, your personality, you can't change. So one thing that I thought could be considered is a recommendation on human capital investment. That in order to run this system, we're going to have to make an investment in personnel to not only at the state level, but at the perhaps at the health system and practice level as well. And it may not fit exactly here, but it certainly could when you're talking about these new systems. It needs to be, personnel need to be identified, trained, and retained in order for these systems to actually be, of course, used. And clearly, it's a challenge for the state, but it's really a challenge for all organizations in some sort of framework to identify how that can be done. I think it's important, especially when you're talking about a quantum leap in the data tools that might be available.
Great comments. I mean, I think these are very important ones, and they are not in the report right now, so we'll put them in. Okay. Any other? So in terms, we kind of discussed a little bit the roadmap. So in the, let me see if I can get that. So we tried to come up with a graphic showing the existing data structures and the sharings related to our project, and also find a way to incorporate the Medicare data. So in the first slide, so we have the health plans, and they have their own analytics doing membership interface and also provider interface. And then they send the claims to Maryland Healthcare Commission's APCD. There's an interaction between them. And then they also have interaction that the claims are coming from providers on the other side. And then we put the HIE in the middle, and they are interacting with providers through administrative and clinical data, and then through the encounter system with the health plans. And then they also, the HIE is interacting with the government entities through different projects that they have and the portals. And then you see the two main data sources that we identified. One is APCD, and the other one is HSCRC abstract data. And abstract data, the provider link, HIE, now it's linked. And we dotted the APCD. I know there's a plan to create the link. So this is the EIDs, so that it's going to be linked with the HIE. Right? It's still the plan? Is that?
I think, just like CMS, the access to the EIDs is not assumed because it's confidential.
Right.
There would be questions for us.
Microphone, sorry.
Oh, sorry. So access to EID level information, just like with CMS, is not assumed because it does, I think we wanted it for Medicaid to do linking. We wanted it for particular research purposes. whether or not it can legally be provided to some provider who requests that information on the patient without the patient agreeing is unclear to us. So, you know what I mean? Because it's a different level of information. You know, because we don't collect names and addresses. There's sort of a legal, and providing mechanism for that, you know, is also something that we have to address, I think. Right, Ben?
Yes. So on the other side, the HCRC one, you know, we find a way to create the EID using the Master Patient Index algorithm that the HIE employs. So we can use that ID to do our internal analyses, but also now, basically, this is depicting there is a way to link the data, but whether you use it in care management with the confidential data or do some analytics is obviously that's kind of based on the data governing rules of the data sets. But there is, you know, you will be able to create that link, and then depending on the use case, you know, that may become available.
Right, right. And you know, we also have a warehouse that would for which we've arranged with SSS for people to buy seats on the warehouse at a relatively low cost. That includes access to SaaS and you know, processing space for people who have that ability. And we're also doing satellite locations of the data in a test mode. And so one of our test modes, it might be to put the data right at Hilltop so that Medicaid could have immediate access. But we're going to expect some quid pro quo. But I think, you know, so someone said there's one-stop shopping, but one-stop shopping doesn't mean you all have to go to the same big store. You know, so it can be located in various locations to make it convenient.
And I mean, I guess my only comment also would be, I mean, whatever we're doing with the APCD should somehow be linked with the HIE. I mean, they've got a mechanism there where they're getting consent. Obviously, I think it's just for hospital users right now, mostly because the ambulatory are connected.
There are ambulatory users as well, yes.
So,
especially with the new PDMP, the prescription drug monitoring, there are a growing number of ambulatory users.
so I guess while you're still building the ambulatory piece and connection, this administrative data would be a great way to build the link between hospital and ambulatory services, at least in the short term.
Right. Assuming, you know, but right now yours is based on having a business relationship with that person, which means if I've never been to that hospital and I don't have a business relationship, are they entitled to see my utilization just because I'm in their service area? And that I'm not certain of. Are you?
No.
We're working.
And I think this, if I may, I think that there will be many sort of particular uses where there's going to have to be an evaluation of whether it's allowable to do that. You could imagine a hospital saying, well, I can go into the data, and in order to, I'm going to find everyone with a BMI that's really high, and then I'm going to call them and try to get them into a program, and that's not going to be allowable. But we'll have to figure out what things, when it is, and some of it may be tricky. I do want to say with the MPI, it absolutely will be able to link these different data sources. And what we'll have to be very careful about is that if you link the data sources and you use the same EID everywhere, then you're essentially giving the key to re-identify all these other sources to anyone at the edge who has access to that information for one of the databases. So that's what will be tricky, and in fact, we'll probably end up needing to use multiple EIDs, and in certain settings, you'll provide an EID that only is within one data set, and other times you'll provide the EID that spans.
So, David, I think our plan, because we recognize that we wanted to have our EID match to the Medicaid and to the discharge abstract. But then when we give the access to different entities, unless they're specifically entitled to that linkage, we will scramble it on our own.
Okay, yeah.
So we will uniquely scramble it so that nobody gets the same EID unless they're cleared and have a purpose and have been entitled to the cross-database linking.
So I think there is, in terms of the right side of the structure, there's a lot of, because of the HIE, there's a lot of connections that are now building in. Before we didn't have it that easily. On the provider side, Patricia Travis asked what the other box is. So this was the ambulatory providers, nursing homes, and all other providers. We just kind of lumped them all as other and separated the physicians and hospitals because hospitals specifically are sending abstract data to the HSCRC. And then here they do have their own care coordination analytics, and they may have their own other data sources that are not here. So I just wanted to get kind of your perspective on this task and whether this is accurate description of the links that you have with the care coordination data, or do you want to add other things that you think are important?
I'm not sure what. So care coordination analytics, are you saying that applies to everyone?
So they have the, basically here it was just saying providers find, they do their own analytics, so it is not linked with any other boxes that we have. And if it kind of speaks to the next one when we put the Medicare coordination data into the picture. Providers are still going to do their own care coordination analytics, whether they do it at the hospital level, they do it at the system level, or they do some coordinated effort.
I mean, I think it's important to keep in mind that when I think of care coordination today, I think of it happening at the practice level, not and then secondarily at the payer level.
Practice, you mean?
Like doctors.
Yeah, I mean, providers, I put it in a larger box, so sorry, my English maybe is not enough for this one. But it's just basically saying providers, depending on who you are, you may or you may not have a care coordination analytics. So just to acknowledge that providers are not just providing services, but they do some of their own, and they will do more with the new waiver. Similarly, on the health plan side, we try to say, okay, they do their own analytics for themselves too. So that was kind of the rationale. And then when you put the Medicare data in here, so who needs to have access to it, and how you would link this data to the existing buckets. So as I said, the government entities are going to get a different set of data, which we may use it for care coordination purposes as an intermediary step. So there's one link. Would you have this data directly linked with the providers? Do we want an arrow there? Do we want an arrow to HIE? Do you want arrow to health plans? That was the kind of the concept behind it.
I'm not the expert, but I'll say I think in looking at that diagram, it might make sense to have those arrows connecting in the places you mentioned. But I'm appreciating that it may be difficult to reflect on the diagram the nuances in the conversation, particularly that Linda, Ben, and David were having about use cases and linking, because even though there's an arrow from the Medicare data to providers, it's not like a provider would be getting that whole chunk of data. Only certain pieces of it are at certain times or only on certain people. So I don't know if an arrow, this arrow is different than the other.
It depends on what type of physician it is, because if it's a physician in the ACO, then they are getting all that data right from CMS. I mean, so like if they're one of your guys at Anne Arundel and the ACO there, they're getting tons of data. They probably have the care management right in their own system, and they're doing whatever they're doing. And that does probably, between all the ACOs in Maryland, we probably have 150,000 lives in those hunks of folks. So they're getting that. And then, I don't know, how many people are Medicare Advantage here? Do you have any idea? It's not very many, right?
It's probably 70,000, I believe it's 8% of the eligibles.
So you got that little bit in that, and they're getting care management from the payer in those cases of some kind.
Right.
Or data and stuff, right?
But when I mean, I may be getting ahead of things. I may be too far behind. I may just be out of step with the timing of things. But as I listen to the discussion, what goes through my head is the use cases. And the use cases, to me, are fundamental. It's identifying gaps in care, and even more important, I think it's producing future costs that you can intervene in and attempt to avoid. So to that end, I think you want to be able to look at a population and stratify it between, I mean, you know the high-risk people are already because you see it in your claims data. But it's almost the moderate risk people and the people at lower risk. To identify the proper interventions, you're going to need, the more data you have, I think the better off you're going to be. You know, as a provider, as a health plan, anybody who's working in the care arena, you want to identify those gaps. And I think you want to provide that, you know, long term in some fashion. As I extend this, and I think ideally, if there was just one entity or multiple entities, the agenda is the same. The destination is clear. Right?
I think the other issue is that in Medicare, and obviously that's our top priority because we have that $330 million number, you know, we have to hit.
Right.
So if you think about it, like about 20% of the folks are in some kind of situation where they're in an ACO, and theoretically the doctor has an incentive to provide care management and look at the data, and they're getting data. And then we have another 8% that are in Medicare Advantage where theoretically insurers should be doing something. And then you have another, and these are ballpark numbers we just figured out real quick, so I might be off, but we have another like 62% that are floating out there where there's really no incentive for the practitioner or the hospital to do anything. So it does seem that we need to figure out how they're going to get something. And I think that's the issue. So I think the question is can we do a better job with these other folks too? Yeah, probably, but we should focus on the ones that aren't getting anything. And then Medicaid too, in theory, you have the folks who theoretically are getting some kind of care management if they're in MCOs theoretically. And then you have people who are like the eligibles where or the handful that are yours just free floating that are state that aren't getting it. And you want to figure out how to get them that if you want to save the system money from a global 10,000 foot. So that's what I think we need to figure out is how are we going to provide care management and data to the practitioners in those settings where you don't have anybody doing it at all.
So I think what you're mapping out here is the infrastructure, and then the separate conversation is all the use cases of privacy and sharing and all of that. But at the minimum, you're trying to lay out the data flow and the infrastructure, and then at some point we'll have the larger conversation around how we can use that data and who can use it.
Right. So I think the alternatives we talked about in terms of the picture is we have a single box for Medicare data rather than us separating small boxes to each user. So what we are recommending is to have a single infrastructure where we house this data, and then here with the arrows we are just going to say, okay, this data needs to go here, but it's a different data and maybe with different governing structure. But I guess I need to move. So it's just that, you know, we are putting a single box there.
Are we saying that we're going to take over the data for the ACOs, we're going to take over the data for the insurance companies? No. So really it's three boxes. It's the insurance company box, the ACO box, and then it's the non-regulated box. And we're talking about having a shared infrastructure for the non-care managed box. Is that what we're really talking about? Or we're having a shaded box? I don't know. It doesn't matter what the box looks like, but in real life that's what we're talking about, right?
Right. Everybody is doing what they're doing already. So this is.
And we're not going to do it for them. We're just talking about the ones who aren't covered. That's what we're focused on. Am I right?
I hear Gene saying, tell me it's not going to be duplicative. Tell me it'll be something.
It's not saying that.
So on the advantage side, to me it's a little easier because there's no data that is going to come from the CMS. So that, you know, they're doing their own thing for the time being. For the ACOs, though, I'm not sure. There might be things that could come up from that box that will be helpful for the ACOs. But it's obviously
Well, the only thing I would say, and I don't want to speak for the hospitals, but some of our members and some of my members have invested a lot of money and time into care management and data and systems, and I think we'd all be really grumpy if we had to pay for it twice. Now, if we could do things that would help us do a better job, we'd probably like that. So we just need to figure out how to work with us. You know, but if I was GVMC or Anne Arundel, or if I was any one of my private docs like Shaw, and you suddenly told them they had to do X, Y, or Z or pay for X, Y, or Z, and they'd already done it, I suspect they'd be just as grumpy as if you told Frank that his company had to pay for something twice. You know, so we need to think about that.
So, but I just say, with all the other ACOs popping up, don't we want to have some type of standardization rather than have, I know the ones that are existing, but if you start popping up 3 or 4 new ACOs, I mean,
but isn't the beauty of it, it's competition, and if they don't make money, they're going to go out of business? I mean, isn't that okay? I know we're in Maryland, but seriously.
but
I mean that in all sincerity, because if they don't save money, they're not going to make money, and they're going to go out of business, and then there'll be another one that will take over, and the world will go on.
But I mean, before, you know, there wasn't any structure. They had no choice. This way, we are kind of providing them the choice. If we have this really well integrated, there might be advantage of using these resources from the ACO perspective compared to building their own.
Well, I think, you know, certainly there's a place for best practices. And I think you want them to coordinate and, you know, come up with some measures that they found useful. You can share those things. It doesn't mean people have to reinvent the wheel or change course or, you know, but they can inform each other's choices, wouldn't you say?
I wouldn't necessarily view it as duplicative at all. And I think the ACOs have established, there are already established relationships with CMS regarding data sharing that existing ACOs have. I think until we have something that substitutes for what's being put in place, it's probably too much to worry about. The data sharing that is occurring between CMS and ACO today, the extent it is occurring, which is somewhat of a, I get different stories. It's agreed to be occurring, but hasn't happened yet. I think we should not worry so much about that. I think, but if we put in place a desirable infrastructure, people will, over time, migrate to that without, even if it does cost a little more, because it's going to be better. And that probably is the best way to approach it, that the infrastructure, to use Gene's term, could serve the non-managed population, certainly, but it may be attractive to the ACOs in the near term, midterm, probably less, only in the long term, attractive to the Medicare Advantage plans. But I think the concept here is to really focus on those unmanaged, which there are quite a few. We want to build an infrastructure that might be more generalizable than the 600 or so thousand Medicare beneficiaries, others that are not managed at all.
So one thing, though, I think we finished this. So one other point that I think is important for Medicare is we want to make sure that it does connect to the HIE. And that's something that even my ACOs would like, because then obviously tools like ENS that we've already invested in, the portal and the PDMD, you'd want that connected in. So I think that's important, and that's good for everybody. Right. Yeah.
So have you gotten permission from CMS to, you know, cycle identifiable Medicare data through the exchange?
So that's kind of our use case scenario that we are proposing. If we get the data, I think, and they've been very impressed with our HIE work and our APCD work, and I think if they turn around and say, oh, no, yeah, you did great system here, but no, you can't link our data with it, I think we need to find a way to link it.
So, yeah, I think that we have to figure out a way that how to deliver the data. There are lots of ways we can construct both, you know, the reports for clinical care and the models for predictive modeling, but you have to have a vehicle, and clearly the exchange would be a way to do that. They've demonstrated already a way to get to support opt-out. That's the direction we go, which might be a place to start. But it's a vehicle that already is delivering data to providers. So that's having to select another framework for delivering results, be they clinical or predictive, would be challenging because we know what it took to get this far with prisoners.
And I would just echo what Ben is saying. When I saw this, I was surprised just that the Medicare box was sitting by itself. I felt like it needed to be linked to the HIE or somewhere there so that there's this translation that would be really helpful for the providers, the hospital providers, to have some type of vehicle to get that information as opposed to, okay, I grab that, and then I have to figure out how to link it to this, and then I have to link it to that, and so I would just echo what Ben was saying.
All right. I think that's a good point. That box needs to be close to or part of the HIE box so that there is a stronger link there, and then it's flowing through to the other users through there. So where does all the predictive modeling rest in the diagram? Is this diagram saying that the hospitals or providers and payers will all have their own predicting modeling capabilities, or are you trying to centralize and standardize that as well? So we try to term it as the Medicare coordination data, but I think it might be helpful to have Medicare claims data and then analytics as a jointed box so that you know that it's happening there and then it is flowing through the HIE. So the analytics are still within this box, but it's not clearly depicted at the moment.
In the Medicare
care coordination data. Care coordination data was, for us, a process data, but we want to make it more clear that you have the claims coming in, but then you have the added information with the analytics there.
I mean, I think that this is complex enough. I mean, I can think of, so I'm going to make sure that, and David's been pulled aside, David Horrocks says, that, you just see a link here between the clinical data, but clearly simply dumping clinical data onto people's desktop is not what anyone wants. And there's sort of the analytical, the counterpart in real time is to predictive modeling, or for the future is, you have to put this in a digestible form onto their desktop, which we've learned from ENS that getting the data to the practice is part of the problem, but getting the ENS data in a way that's manageable and operational to individual physicians is another step of the way. And simply saying the practice has the data doesn't mean very much if it's not operational and somehow integratable into maybe not right now an EHR, but available on a desktop that it can be manipulated. So we can get, I think this is sort of, I see it as the data sharing, and I wouldn't want to clutter this up with too much about analytics, et cetera, but recognize these are data flows, what sits beneath them can be spelled out maybe in another diagram, but putting, I wouldn't want it to turn into Dean's, is what I'm saying.
But I kind of feel it's unclear now what this data is. I think it's kind of making sure we define this in a better way so you know what we are talking about. It's not, here we didn't mean just the claims data. That's, I think, and by separating those, I think we could be clear that we're talking about the
you can
actionable data.
I mean, this is just, it's submitted information and derived information, which sort of cuts into the modeling concept, I guess. I thought it was both submitted and derived. I viewed it very broadly. Those are just data flows.
So, I mean, yeah, that's interpretation, so I'm just saying we'll make it more clear. So it's both here. It's both.
Right. And I did want to point out that, hospitals or other people can get direct access to the medical care database. It doesn't, they can create their own analytics, or you can hire someone to create analytics for you. So there's also the possibility for direct access. So it isn't, there isn't only one place to get it.
But you'll always be limited by the fact that you won't know who these people are when they access it.
You know, when data is kind of old, I mean, I think you can use it, as Shulay said, you know, for predictive modeling. You want a lot of data, and you look at it, and then you can flag those people. And I think their direct providers could, if the patients agreed, let them know that this person struggles with A, B, C, or D. But, you know, whether it's the idea that you can that the average physician would want to see a history of claims data to manage a patient today is.
So I guess one maybe concrete example, I'm a big hospital and I want all the physician claims of the patients that I'm seeing. Can they go and get it from APCD?
Probably not in this direct access, but let's say that I was a hospital and I wanted to look at in my service area, my hospital service areas, and see how people were being managed and who they were being managed by in my hospital service area as a planning, as a business decision, not patient management, business decisions, to make a plan for how I'm going to build an infrastructure. That's like, to me, the optimal use of a lot of experiential data in a particular geographic region where you know who the docs are, because you can tell from the provider identifiers and with the patient flows, and you could see who the, you know, who the diabetics who showed up. There are diabetics who show up in your ER, and there are diabetics who don't. And so, is there a difference in who's treating them? I mean, you couldn't.
The identified data, right?
Right. So they can go back and say, okay, this is my patient A. I was most concerned, and this is the physician that they are saying they won't be able to do it through APCD.
Yeah. I mean, in terms of thinking about APCD, in terms of a management, we would have to discuss changes to it.
Well, that's why I said it's the business. A lot of it is legal. It isn't just you get to decide. So I think the legal issues have to be worked through.
I mean, I think maybe we can talk through some of those legal challenges and lay them all out in terms of what. Not only that, but changing your statute in terms of allowing you to get identifiable information. I'm throwing it out there. I think, you know, those are things we should discuss and figure out. I mean, obviously, we would have to think through all the privacy, but it seems every time we talk about the APCD, we're doing all these workarounds to eventually get at giving someone the information of who this patient was.
All right, we will have some work to do, try to fit the Medicare table there on the roadmap. So I'm going to move to, it's kind of related, and unfortunately in the presentation there are some general stuff, and then but what you were talking about in terms of the broader concept, what data we need, what use cases is, we felt that it is really related to the work of other work groups and more a collaborative work is needed. It's hard for us to here sit and then think about the data sources we have in the absence of what's going to happen with the ACOs, what's going to happen with care coordination. So towards the end of the presentation, I would hope that you can bring your views into how we should structure this process for this phase 2. Just briefly, just kind of recap where we started and where we are now. I think we are on our way to the midterm 2015 scale because we had the work groups in phase 1, and we had specific charges, and that was an input from the commission as well as the advisory council for us to say focus on high-risk Medicare users, focus on the immediate needs, and with that concept, our charges were really looking at the first 6-month period, the short-term period. In phase 2 now, we are moving towards more thinking broadly what our implementation goals should be and getting ready for the phase 2 of the model. So that's the long term, so we are in the kind of midterm now where we are in this phase 2 of our first phase. We had 4 work groups, and organically we ended up having small work groups meeting for specific groups. 85 appointees and very well participation, and I also personally thank you all for coming here and being online. I think it was a great experience from our perspective to hear you and get your help in the process. And I think this has kind of expanded our traditional work group work where we really dealt with the people that we know. I met quite a number of new people through the process and a lot of new voices that we start hearing from the consumers, providers, and also from employers. And also we tried to make this as public as possible. As you know, everything was published on the web, and we provided opportunity for public comments, and we will continue to do it that way. And we heard great feedback from especially consumer groups who are participating, that they liked that it was all readily available in a timely manner. The role of the work groups are, as I said, kind of get the input from the variety of stakeholders into the process and have the commission to better informed on the decisions that they need to make in the new model era. And we purposefully, the work groups are non-voting groups, and we try to reflect the consensus and the dissent in the reports that we drafted. So we're hoping that you know, we try to reach the consensus, but at the same time, if there is none, you know, there is none. We can't produce one. Looking forward, in the first phase, we really had aggressive timetables, but very defined job description. Moving to the next phase, we think that we need more time to think through certain things. Now we have broader goals that will require a lot of more preparation. So we are going to have more less frequent meetings and more small work groups to prepare for these large meetings, so that when we meet, we have substantial discussions based on the formal input. In terms of our work group, I think we accomplished what we were charged with the 2 products that we published. One was on the data sources, monitoring requirements and the gaps and ways to get it. And we've been working with CMMI officers to review those monitor metrics that you all looked at, and then producing the numbers and the results to it. And on the total cost of care reporting, we have been meeting individually with each payers who are willing to meet with us to get their feedback on, and we are going to continue and at the subgroup level to come up with uniform definitions and timetables for it. And then the second output is the draft that we reviewed, and I think it's almost done there. Then what we did is we kind of looked at all the other work groups. If you remember, we have a physician alignment work group, performance, and payment, in addition to data. And we pulled the things that were relevant for data infrastructure work group. On the care coordination, we are thinking that it might be, it's been discussed in the physician alignment, in the performance, even in the payment. All and us, we've been talking a lot about it. Our idea is maybe to bring a group of people together, really focus on care coordination for all the aspects of care coordination rather than the subject relevant for each work group, so that it could be integrated in a more organic way rather than, you know, the staff and the report function. And then they'll be looking at the access to Medicare data, you know, version 2, the phase 2. Define specific use cases and analytic needs, and kind of going one step further in our discussion to integrate what the data infrastructure needed based on those discussions they have on the care models. On the monitoring and evaluation, total cost of care analysis is continuing in that area. We also have GBR global budget revenue reporting templates that we are going to be working on. These are the performance templates that hospitals report to us on a monthly basis, their total revenue, their readmission rate, their complication rate, and there might be other things related to the investment that they are doing on the care coordination. that may be part of these templates as well. On the data to support other new monitoring, so there are issues around, the payment policies that we need to come up with on the market share and the transfers. There obviously, depending on the policies we accommodate, there might be new data needs or new submissions that we need to have on that area. In the performance measurement field, we talked about the EHR link and the claims and administrative data linking together. They have a task in the intermediate term to look at new measures that could be derived from the EHR data, and that would also be linked with the some of the discussions we had in terms of closing the gaps in the claims data. So it's the closing the gaps in the performance measurement perspective. Obviously, they also need to think about the new measures for the care coordination interventions implemented and how we can make sure that we can evaluate them in a more uniform way across the state. And the payment one, again, the total cost of care is important for them because there might be payment policies associated with shifts in care. And also, they are the body who determines how much money that will be, or who inputs into how much money we need to invest in the infrastructure for care coordination. So with that, again, the idea, our data work group touches on all these aspects in one way or another. So we are, our idea is effectively we would like to get volunteers from you and then find a way for you to integrate those discussions into the other discussions that we are having with the other work groups, and then not meet for the time being and see what those discussions happen, and probably 6 months from now we will have a better understanding of where they are in terms of the substantial issues that they need to discuss. So if if the state has a care coordination model 6 months from now in a more concrete way, then there might be a need for us to get together again, given what they decide on the use cases, to think about again what the data infrastructure needs that we may need to think about. So that's kind of our proposal to you guys, but I want you to kind of give me the feedback on how we can do this transition in a better, effective way. Sound good, I guess? Sergeant is a good thing?
I think it's a great idea. I mean, all along there has been some overlap within the work groups, and it has made sense. This group has had two very discrete tasks to focus on, so it made sense to have a work group focus on that, but it's always touched these other work groups. But now that that work is done, I think it really does make sense to do exactly as you described and integrate for a while and then reassess.
Mm-hmm. Mm-hmm. And so the existing work groups, the other work groups are going through a transition too. So once we have a more defined charges and the roles, our idea is to send those to you, and then you can volunteer yourself to any of the work groups that you think you would like to be participating and spending more time with us, and we'll go from there. Sounds good. All right. Let's see. Public comments. Any public comments or anything from the webinar? No. So then the finalizing the report, we are going to revise the draft, and if you have anything that you did so far, please send us to us as soon as possible, and we'll send you the revised version early next week, and this is going to go to the commission meeting for July. So that's the plan.
Give us a deadline to respond.
Yeah.
I think we'll send a revised version based on the comments today, early next week.
Mm-hmm.
We still have a little bit more time before we send it to the commission meeting, so you'll have another, probably till the end of the following week, I think.
Yes. Yeah, 10 days to 2 weeks. Mm-hmm. Yeah, when I send the draft, I'll make sure you have a deadline on it. All right, thank you so much. And again, I appreciate all the feedback and the diversity of the opinion. I think this was great discussion, and our report we'll see how it will go with the commission, but I'm sure it will be received fine. Thank you. All right.